All right, so introduction, my name is Andrew Schmidt. I'm an assistant professor here in emergency medicine. Did my residency here and now in third year as a professor. Also deputy medical director of Trauma 1. I focus on education, outreach, and training. So thank you all for coming. I hate to see a lot of familiar faces from pre-hospital nursing and physicians, so great to have everybody here. All right, there's this smart guy in the crowd. He's right there, actually. He's not even paying attention. I'm lasering his face. So, there are very smart people in this room, and what I'm going to cover is pre-hospital literature. And there are very smart people in this room. One of them happens to be Dr. Fahim Gurgis, who could tell you everything about meta-analyses and everything about cohort studies and retrospective and all that crud. And then there's this guy. And so you always need to kind of bring it down to the lowest level, and I think that's it right there. So I'm going to try to present this information in a way that I can understand it, so hopefully everyone else in the room can understand it, because literature reviews can be kind of daunting, and I don't want to lose anyone. So if I start losing you, please make me stop and explain what's going on. What I want to do is take the literature from the last couple of years and some major topics that we all kind of see, mainly the last 3 years, grind them all up for you and make a nice summary sausage for you to digest easily. So again, hopefully this will be useful to everyone on every level. Each disease we talk about here we all see and we all deal with on different levels. So here we go. It is an ED trauma symposium, so we're going to cover both ED and trauma topics. In the ED, unfortunately, we have a lot of Narcan usage recently. Dr. Melissa Mann's going to talk about that later and why we're having such an epidemic in our community. Narcan being a reversal agent for narcotic medications. Cardiac arrest, always a hot topic in emergency medicine. How can we better improve our outcomes with cardiac arrest? Trauma, we're going to talk about needle decompression. There's some cool evidence that's come out in that to make our procedural skills a little more efficient. And tranexamic acid, or TXA, something we use in our hospital, and we're starting to see more in our pre-hospital phase as well. So let's get started. We've all had this patient before. They come in from the street, just completely gorked out of their mind. They might be a GCS3. Dr. Tavanapur was just talking about that. There's other reasons for GCS3. The most common reason I've seen over the last 6 months is heroin. So this person comes into you. They may have seen them 10 times before that month, and you kind of know what the deal is. So we give naloxone. That's a nice reversal agent. It's a beautiful drug. What it does, it binds up all the receptors that the narcotics like to hit, and it pisses the patient off because now you've just taken their high away from them. It also pisses the nurses off because now they're crapping all over the bed and vomiting. It pisses us off because we get punched in the face, but it saves lives. So I guess there's a bright shining star in there somewhere. But then the patient looks like this. They wake up, they're happy. They say, "I'm ready to go, doc. You just took my highway. I don't want to talk to you anymore. I'm ready to go." And you're like, "Dude, you just weren't breathing. I saved your life. You're welcome." But they want to leave. So there's a big ethical dilemma with this, and we're seeing this a lot. And the residents ask me this a lot, like, what do we do with this patient? Technically, they were just dead. We brought them back within 30 seconds. Naloxone likes to wear off in 15 or 20 minutes, so how can I rightfully let this person go knowing that in 20 minutes that's going to wear off and they're going to pass out on the sidewalk? I think any of you who work in emergency medicine have seen this patient probably sometime this week. So we have to figure out what to do with this, especially in pre-hospital phase. I hear this from the pre-hospital guys and girls all the time. Yeah, I gave it to them on the truck. Suddenly they want to sign my AMA form. What am I supposed to do? How do I cover my butt and rightfully say to a court of law, "Oh yeah, let that guy go," knowing the naloxone is going to wear off? But luckily there is some literature to kind of help guide our treatment with this. So, did a quick search the last couple of years. This first study right here was by Levine, and it recently came out in March. And what they did was a retrospective study. So what they looked at was all their cases back the last couple of years, 3 years, and compared that with death data. So they found all the heroin patients or narcotic patients they gave Narcan to. They compared that with death data from autopsies and medical examiner offices, and tried to figure out if any of those patients that they gave Narcan to and then walked away or AMA'd, if they then died because of reintoxication. There was a total of 205 patients, and from that cohort they had one death within 24 hours. Was not immediate, so likely not due to reintoxication from that acute ingestion, could have been a subsequent ingestion or something else. And then they had 2 deaths within 30 days, at 6 and 20 days. So again, not associated with that acute ingestion. So again, gives us a little sigh of relief that, okay, these people aren't just walking off and dying. All these studies I show you are low quality evidence. You can't randomize this kind of data. So what we're looking at is retrospective chart reviews and really trying to capture the best data we can. It's not the best data, but it's all we have. Another article I'll talk about, this was a review article that was published this year, just in January, just came out. And it said the goal of this review is to determine if a treat and release policy is supported by the current available literature. And what this was looking at is actual systems in Europe. There's a couple pre-hospital systems in Europe where they have a treat and release program where the EMTs or medics or nurses or docs, whoever's on the truck, come up, they give Narcan, they watch the patient for 15 or 20 minutes. If they're at their baseline, they release them. And this is a policy they have within their agencies, and it's been fairly successful. So what this review article did was, well, based on that, can we safely establish these programs in the US based on the data that we have? So they looked at a couple different studies. This first one out of Copenhagen had 2,200 patients. That's a pretty cool cohort of patients released on scene, and they looked at any deaths within 48 hours. So there are 14 deaths possibly by rebound toxicity, but when they really looked at it and looked at the data, looked at the coroners to see if they had morphine derivatives in their blood and all that stuff, there are 3 deaths likely by rebound toxicity. So 3 out of 2,200, it's a 0.13%. So yeah, 3 deaths sucks, but it's pretty low actually when we're releasing 2,200 people. So again, this is actually some of the most robust data we have. This is the largest study that we've seen on this. The rest of the review is based around 4 other studies, much smaller studies, but again, the only data we have. Vilk has done 2 studies out of San Diego with 317 and 998 patients, no deaths within 12 hours. Again, same model where they look at all those patients they gave Narcan to who AMA'd, and then look at the medical examiner records and match the 2. Wampler out of San Antonio, 552 patients, no deaths at 2 days. And then Boyd, no deaths within 12 hours of 84 patients. So a nice big review article. Just kind of rounding up the most recent literature on this. Summary, low risk of death, but it does happen. Again, the biggest one we have says 0.13% is the best data we have. So it does happen. So education and then stress observation. I was talking to my residents today, and the way I approach this, and it's pretty darn successful, is I just go to the patient, I talk to the patient and say, look, I just gave you a reversal agent. It lasts about 20 minutes. If you hang out with me for 1 hour, I'll give you all the Gatorade and sandwiches that you want. And after that hour, you can walk your happy butt out the door. And 90% of the time, that's okay, that's fine. You do get a couple people that they just want to go back out. May want to go back out and get a high. They just don't want to see anymore. But for the most part, they really are okay with putting an hour aside out of their busy day to hang out with you and eat some sandwiches. So again, this is just talking them down. I'm having a good conversation with them, not being a jerk, and we can actually maybe avoid some badness. Any questions with that? That's Narcan.
They're good sandwiches, though, aren't they?
Damn good sandwiches. They bring the patients in. All right. Yes?
Any of those studies looking at prescribing Narcan? Or like sort of
all of those studies, those 5, were all based on AMAing from the pre-hospital phase. So what Dr. Shannon was asking about prescribing Narcan. Because as you've probably heard, that's a big thing going on. It started up in the Northeast, where and is mainly for families with kids or family members who had a problem with narcotic overdoses. They're able to take home a nasal spray, Narcan, naloxone, and if they find their kid or their family member down in the room, they can hit them with that and save their life. And it's a huge ethical thing. Everyone goes down different sides of this because there's the thinning of the herd thought, and there's also the, well, we got to save everyone thought, and there's everyone in the middle. And then all these new devices have come out. I was working up at our North Campus recently, and someone came in and they handed me what looked like a pager, essentially. And it was a Narcan auto-injector that talks to you. And so essentially you take it out, and someone had used their own on this person, unfortunately, because they didn't know this person. Those things cost $700. But you take it out of the little case, and it tells you where to put it on the patient and what to do. And then when you take it out again, it says, this device has been used, please replace. So yes, a lot of companies making a lot of money out of it, but very interesting. We're seeing a lot of police using it as well. There have been studies recently showing very high success rates with officer-based programs. And a lot of YouTube videos where officer walks up, they know this patient, they've seen this patient, bam, Narcan up the nose, 30 seconds later, they're breathing again, they've saved a life. So that we are seeing some new data with that. So cardiac arrest, one of the hottest topics in emergency medicine all the time. We're going to go through some of the new literature in airway, compressions, and defibrillation. In terms of airway, a quick history, there's always this question, should we be tubing patients? Every medic wants that tube, man. When I was in the field, I wanted the tube so bad. And then when I started becoming medical directors places, my friends were so happy, like, oh, you'll let us tube all the time. And now I'm like, stop tubing so many people. Because that data actually shows we might be doing more harm in the field. Our success rates in field intubation are already very low, just because most people don't get much practice in the field, and it's a terrible situation. When we are intubating in the ED, we have every light, every resource, everything we possibly need. When you're crouched down the back of the truck or in an alley somewhere, it's not going to be a good outcome. So there are actually some big studies. This one had about 650,000 patients and found that advanced airway was associated with decreased odds of neurologically favorable survival. That's not good. So what we found is the intubation is increasing our hands off the chest time. So when you say, hold on a second, I got to intubate, all right, we're now no longer doing CPR. The focus is getting taken away from high quality CPR and defibrillation and put on the airway, and we're also suffering hypoxic injury. So these people aren't walking out of the hospital neurologically intact because we're trying to intubate them. The other big study, about 10,000 patients, they found that survival was higher in patients who received no advanced airway than those who either received intubation or supraglottic device, like the King Airway or a combi tube. So again, these are the kind of two big studies in the last decade or so that kind of set the way for really pushing more toward maybe supraglottic devices or bag valve mask in the field. So looking at the recent literature, let's kind of see if we have an update since then. So this study right here in AGEM last year was a meta-analysis. Essentially what a meta-analysis is it takes a lot of different studies looking at the same thing. It pulls those patients together into one cohort pool, and then it compares them and uses different statistical models to come up with some good numbers and recommendations. Again, it's as good as the quality of the articles it's looking at. So if you're looking at 10 crappy articles, it might be a crappy meta-analysis. And a lot of this data is not good because, again, it's not randomized. But again, it's the best data that we have. So what they looked at is basic airway maneuver, so opening the airway, bag valve mask, NPA, OPA versus intubation or supraglottic device. What they found was the advanced airway was associated with decreased survival. All right, so intubating was associated with decreased survival. There's no neurological recovery difference between the two. When they looked at just intubation and basic airway maneuvers, there was no difference. So again, a lot of these meta-analyses, you get kind of crisscrossing, overlapping outcomes, but they did have an outcome here that showed that advanced airway caused increased mortality. Weak evidence in general, like I said, a lot of heterogeneity. There are a lot of differences in the way the studies were done and what they looked at. And 2 randomized control trials are now in progress. So that'll help us really get some better data. Questions? Yes, smart guy.
They come in with CPR underway,
Mm-hmm.
and they come in with either no airway or a supraglottic device. How do you address the airway?
So what Dr. Gerge asked, if they come in with CPR with no airway or a supraglottic device, how do, I'm guessing he asked me personally address it, or? Yeah, so I really like supraglottic devices. Most of our agencies around here, JFRD, NASA, Trauma One now, we use King device, the King Airway, which I think is a beautiful supraglottic device. And I like it because you can teach it in 30 seconds, you can place it in 30 seconds, and it's really successful. And again, in our code situation, I do not want that person stopping CPR for anything unless it's defibrillating or ultrasounding the heart. So if someone comes in with no airway, I personally am very quick to grab a supraglottic device and put that in, especially on our codes up on the floors, and then let everything kind of pan out before we intubate. I'm also okay calling codes and resuscitations with a supraglottic device in, as long as we have good evidence that's working. And if it comes in and it's working, so we have equal chest rise, we have pretty good sats and good end-tidal cap, I'm keeping in and doing my entire resuscitation with the King Airway or the supraglottic device in. If it's not working, you take it out, bag them up. If you're bagging, you're getting good chest rise and good sats, just keep doing that. I'm not going to stop my compressions. All right. So the main thing I want to look at compressions, you can look at compressions in many different ways, but what I want to look at here is manual versus mechanical. Because this is a big question. Most of our agencies have mechanical devices, a mechanical being a machine that actually compresses for you. Our ED, we have the Lucas device that we kind of put behind closed doors for the last couple of years, and I'm really fighting to get back out because I really like it. But everyone is trying to figure out, well, does this actually make it better? We always think machines might make things better, but we really need some data to guide us. So this study here, subgroup analysis of the CARES database. The CARES is just a very big database, statewide database in different states that looks at cardiac arrest. And they looked at 3 years, compared patients with manual versus mechanical defibrillation, or compressions, about 80,000 patients, most of which had manual compressions. There's a small but significant difference. So manual CPR actually increased survival to discharge. So a person just pumping on their chest instead of having a device do it. And manual CPR increased neurologically favorable survival. I put these numbers here because look at these numbers. They're saying an increased survival 4.6 to 5.9. That means 6% of the patients were walking out of the hospital neurologically intact. So I just put that up because that's terrifying. That's just a call for us to improve everything we do in cardiac arrest. Next study here, meta-analysis looking at 20 studies, again 15 observational and actually 5 RCTs, so 5 randomized controlled trials looking at this. For survival to hospital discharge, what they did with this is they broke it up between observational, which were our low quality studies, and our randomized controlled trials, which are our high quality studies. And our low quality studies showed small benefit with mechanical, and the RCT showed no benefit. When we looked at ROSC in the field, so return of spontaneous circulation, there was a significant benefit with mechanical and no benefit when we looked at the RCTs. In the neurologic outcome, there's no benefit either way. So again, essentially what that says is that study's all over the place. It doesn't really answer great questions. One thing we do take out, but there's no significant harm due to mechanical CPR. So this is a study you can look at whatever way you prefer. You can kind of make the study work for you. But there wasn't a huge difference. You saw the difference in neurologic survival of 1.2%, so not a big difference. And then observational, this is out of Utah's CARES database, 16% with mechanical. They said neurologically intact survival was worse with mechanical, and that's actually a pretty good difference, 11% versus 4%. So the manual people actually getting hands-on compressions did better. It is important to note that only that half as many patients in the mechanical group had witnessed CPR or had a shockable rhythm. So at baseline, they were a much sicker group and didn't have a good outcome. But again, it's all the data we have. So I'm going to give you a summary of cardiac arrest at the end here. Any questions with compressions real quick? Yes?
Are they saying it's a lower rate because of the time it takes to put the machine on?
That's a thought. First off, they just don't know. Maybe it just doesn't work as well. Maybe these great machines we think work well don't work well. The concern, what she brought up, and rightfully so, is the concern that putting a device on takes a lot longer than just putting your hands on the chest. And you have to, and that's why a recommendation at the end I'll talk about. And what they did show in one study where the agencies in the field that showed higher survival rates with mechanical were the ones that used it the most in their protocols. It was the ones that just every now and then the crew decided to bring it out. They showed bad outcomes. But the ones that used it 100% of the time, 80% of the time, and had the most practice, they had good outcomes. Because there's a great video out there we were just sharing the other day over email of how to put a Lucas on with only 3 to 6 seconds of off chest time. So it's all about practicing. You don't want to break this thing out and do it for the first time on an actual real patient. So defibrillation, the last thing I'll talk about with cardiac arrest, and we're going to double the fun with double sequential defibrillation. So something you might hear about, especially in our department. I keep liking to throw this out. It sounds like a crazy thing, but essentially using 2 machines at the same time. And we'll talk about some data, because this is the sexiest thing coming out of academics right now. Everyone likes to talk about this on the podcast. So it's kind of cool to know what's going on. So double sequential, the idea that most of our patients right now are getting this placement, the blue pads. This is the placement we're getting. They may also get anterior posterior. But either way, whatever they get, the idea behind double sequential is putting a second pair of pads in the other place and then shocking at 200 to 360 joules at the same time with both machines. And there's a couple theories why this works. At first they thought maybe it was just the actual load of joules you're giving the heart, but now it's thought that you're just hitting the heart from as many axes as possible and hitting as many myocytes as possible. It's thought that you need to hit at least 90% of the myocytes to get effective defibrillation. So what it's doing is ensuring that. Other people think, well, maybe it's just because they're finally doing the anterior-posterior positioning and that works better in general. That is a great thought. That hasn't really been teased out in the literature. So I'll go through a few case reports and then actually have a study. Did you have your hand up or just raised it? Yeah.
I've heard, I don't know if you've come across anything, I've heard through the grapevine of, we all have that fear of being shocked all the time.
Yep.
I've heard that some places are actually practicing hands-on defibrillation.
Yeah, so we'll
Have you experienced or
I'll touch on that real quick because we're running out of time. But yeah, so there's a thought of hands-on defibrillation because you're not having any hands-off time. I have personally performed it back in residency when I was expendable, not worth as much. No, but there have been some cool studies where they showed, and they have studied this with live people and also impedance devices to test how much voltage is coming off the patient. As long as you have intact rubber gloves, you are safe. Some places have a policy where you have to have 2 rubber gloves. Some places have a policy where they put a towel between you and the patient. Again, I did it once, and I just said, no, really, go ahead and shock. I'm fine. Felt the tiniest tingle. It is funny that the one person, Scott Weingart, who really pushed this really hard in the emergency medicine world, he pushed this so hard, and about 6 months later came on his podcast, said, guys, don't do it. I got thrown across the room. So it's one of those things. It makes sense, but that is why I personally love mechanical devices, because you can do that and you're causing no harm to anyone else. I have lots of other reasons why I like them, but that's one of the reasons, is that now you can do that. You can shock right through, because our Zols that we're using now in our department and on JFRD, you can actually filter out your compressions to see your underlying rhythm. So I can keep doing compression and say, no, he's still in VFib, we're going to shock that. All right. So case report number 1, 40-year-old male struck in the chest against a pole during struck in the chest during basketball. Well, this is called as commotio cordis. You get hit with an object in the chest, it hits it on the wrong part of the EKG, sends you into VTAC or VFib rhythm. He received 3 shocks on scene with AED. ALS got there, 3 more shocks. He was still VFib. A 7th shock was unsuccessful. They put the second pair of pads on, double sequential. He came out, got ROSC, and survived with near normal neuro. Case number 2, 7 patients, case series, all refractory VFib who got more than 3 shocks. Mean number of shocks, it was 5. VFib converted in 5 of the 7 patients. 4 survived to discharge, 3 normal neuro. So again, for some of those patients you think about, man, we would have given up on this patient. We had a patient the other night, refractory VFib, 8th, 9th shock. We just said, there's nothing else we can do. So these patients, some of these patients you may have given up on, we might be trying this more now. This one, 28-year-old female, ended up having long QC syndrome, immediate bystander CPR, 6 shocks by EMS, got double sequential, walked out of the hospital, normal neuro recovery. So again, these are all case reports, some of the weaker data you can have, but it's somewhat compelling. So this is a retrospective cohort, looked at 50 double sequential defibrillations versus 229 standard single defibrillations. Double sequential showed no association with neurologically intact survival. So again, now we're actually getting into real studies that are comparing 2 things, not showing any survival benefit. In this one right here, they looked at 12 patients. This is a retrospective chart review. 9 converted, 3 patients had ROSC and survived, and 2 had good neuro outcomes. So then you can make the argument, well, we're actually making people survive that are vegetative state now. Is that a good thing? So you can look at this from many different directions, but I just want to get this in your mind because I promise you will hear about it, especially if you walk through the hallowed halls of our emergency department. Summary for cardiac arrest. Possible harm from advanced airway, consider bag valve mask or supraglottic device. When I see a good placed King airway come in and I know that rescue crew did not waste a second on scene, I'm as happy as can be. Don't let intubation impede high quality CPR or early defibrillation. There's equivocal evidence for mechanical compression devices, but if you use it, practice it, have a protocol for it, and check perfusion. When someone comes in with JFRD, when they come in with their device on, I say keep it on. The first thing I do is I check my femoral pulses, I'll check my carotids. If I have good flow there, keep that thing on. Unless there's some other extenuating circumstance, because I got good pulses, I'm now decompressing my recess bay, and I can use people in other places. And then double sequential defibrillation is possible, and it converts otherwise refractory VFib. We just don't know survival benefit. All right, any questions on that? All right, moving on to our trauma portion. So now we got needle decompression. Again, another sexy procedure. People love doing this in the field. The problem is it's but it's usually not successful in the field. They come in the trauma bay, we end up pulling that catheter out, and it's kinked because it's gone down the wrong tissue plane, it's too short. It's honestly not successful a lot of time unless you have the right placement and the right equipment, and that's what we're going to talk about. So classic teaching is second intercostal space, mid-clavicular line. You ask anyone who's ever gone through first responder, EMT, paramedic, they can recite that in their sleep. That is our classic teaching right there as to where we place this. This also, they usually talk about maybe a 14 gauge catheter, the biggest IV you have. The problem is we don't often talk about the actual length of it, and that's what's important. Yes, big gauge is important, but we need to actually make sure we're reaching the cavity that we want to reach. So coming through the recent literature on this, there have been some kind of cool studies looking at ideal needle length. And the way they did this is a meta-analysis. So again, looked at lots of different studies, pooled the data together, and then came up with a conclusion from that. And what they did is use CT analysis and ultrasound. So a lot of places, trauma centers, they said, well, we got CAT scans on all these people. We scan everyone that comes in the door. Let's just look at all those CAT scans and actually measure the average chest wall thickness of patients coming through our trauma center, and then determine what would be the ideal needle length. And so from this group, they found they had about 2,500 patients, and the mean thickness of the chest wall was 3.25 centimeters. So some of the IVs people use 3.75 centimeters aren't going to make it. ATLS, last time I checked at least, recommends a 5 centimeter catheter. So again, that's only going to make it, based on this data, 72% of the time. So this is a life-saving measure. We need to ideally do better than 72%. And that's the absolute maximum we're going to get with a 5 centimeter catheter. And then a recommended length for 95% of chest walls was 6.5 centimeters. So again, this is a great study to help guide your protocols and SOGs and equipment selection. This is a systematic review and meta-analysis. Looked at the chest wall thickness at various sites and success rates with 5 centimeter needles. They looked at 3 different sites. Looked at the classic second intercostal. They also looked at mid-axillary and then anterior axillary between the 4th, 5th intercostal spaces, and compared those to see which had the highest success rate and how thick the areas were. What they found out was the midclavicular line, what we classically teach, again 5.28 centimeters, so similar to that last study. The mid-axillary line was 3.99, and anterior axillary line is 3.43. So if you look at some recent SOGs and protocols coming out of EMS agencies, you're seeing them actually move to anterior axillary line. And these studies have actually changed my practice. If I'm going to place a needle, that's actually the first place I'm going to be looking. The mean failure rate, and again, our classic position, 38%, mid-axillary, 31%, anterior axillary, 13%. So higher success rate, less thickness of the tissue. So again, here's what we're looking at here. We always hear about mid-axillary, but anterior axillary, this is kind of your axillary area, so just that anterior line right here, that's where we're looking. We're commonly replacing chest tubes and stuff in the trauma center. So summary for that, use the right needle length, 6.5 to 8 centimeters. If you go back to your agency or your unit or your trauma center and you're not using a needle in this length, change it. Change something. Don't just be stagnant, change it. Use the right location. Consider 4 to 5 intercostal space on the anterior axillary line. You'll have a higher success rate. And finally, tranexamic acid, TXA. We are also seeing this come out definitely in trauma centers and in some of our agencies, including Trauma 1 flight crew. We carry this as well. So what happens when you bleed? You cut yourself, fibrin binds and all your red blood cells and platelets and makes a nice little clot for you. You also have this other cascade, plasminogen gets transformed into plasmin, and what that does is actually cut up clots. So your clotting cascade is kind of give and take. It doesn't want to clot too much, it doesn't want to clot too little, so you always have different enzymes doing different things. The idea behind TXA is it blocks this and it doesn't allow this to happen. We have a bleeding trauma patient come in, and it makes sense that we don't want them breaking up their clots. We want them to clot to stop the hemorrhage and reverse the problem. So that's the idea behind TXA, is blocking that cascade. So this is all based on the CRASH-2 trial, a huge trial done in 2010. It was 40 different countries, 247 hospitals, randomized placebo-controlled trial. You don't get these kind of studies every day. And what it looked at was giving either a placebo or giving a bolus and a drip of this medication called TXA. What they found was decreased all-cause mortality of 1.5%, decreased mortality secondary to hemorrhage of 0.8%, and most benefit seen if given in the first 3 hours. So not huge numbers, but again, when we're talking about bleeding, dying patients, usually who are younger, healthier patients than a cancer patient who, there's really nothing you can do to stop that, but we can stop this bleed and save 1% of the population that comes in. That's actually kind of cool. So this made headlines everywhere and started changing protocols. It was all over the place. There was definitely concern. There was lots of questions about the methodology. Some other studies that have tried to reproduce these results have not been able to reproduce the results as well. There's also concern for increased thromboembolic events. There's a large military trial called the MATTERS trial that actually showed people had increased DVTs and PEs, which makes sense because you're now clotting more. So these are the concerns. And there was a joint statement by American College of Surgeons, ACEP, and the National Association of EMS Physicians. We recognize that insufficient evidence exists to support or refute the pre-hospital administration of TXA and are awaiting the results of several pre-hospital studies currently in progress before making a recommendation regarding pre-hospital use. And this just recently came out. So these are two big guns in our community here, really saying, don't get too excited. We need better evidence. But we are seeing it a lot in the community. So our more recent papers that we're seeing, this is a double-blind placebo-controlled trial of early TXA in the swine uncontrolled hemorrhage model, so a pig model. What they did, they anesthetized pigs, they cut them, they had a controlled hemorrhage, they gave either TPA or TXA, TPA would not be good, TXA or normal saline, and then they looked at outcomes. So the anti-fibrinolysis confirmed by labs. All that meant was the TXA worked. They were able to say, yeah, the TXA worked based on our labs. There was no reduction in blood loss with TXA, but there was better survival in the non-TXA group. So this actually showed better survival in the ones not getting TXA. Remember, this is a pig model. They do help guide our treatment and guide our research, but pigs aren't so much like humans. Then we had the pre-hospital administration of TXA in trauma patients. Retrospective Germany trial matched TXA patients with patients who did not get TXA. And what they said was the TXA patients did receive less blood and platelets. It was not significant. Early mortality was significantly lower with TXA, and overall hospital mortality is similar. So again, no huge conclusions coming out of these studies. So summary, the biggest trial shows benefit, but there were a lot of questions with it. People aren't really sure what to make of it. If you have it in your protocols, the people you want to consider it for, non-compressible bleeding, people who are super sick. So we know it does well in people who are super sick, and then less than 3 hours out of injury. Greater than 3 hours, there's actually evidence it might cause harm. All right. Most importantly, don't forget the basics. Nothing saves more lives than direct compression. All right. So don't go to your TXA if you have a nice wound here that you can just compress, use a tourniquet, and use much more rapid measures for. All right, I'm going to be wrapping up here. So the main thing I want you to take away from this is that there's evidence out there every day coming out. And your protocols cannot be stagnant. Stagnant protocols kill people. So you have to be vigilant and stay on top of what's going on in the world out there. You got to investigate for yourself. You got to read, listen to podcasts. You got to talk amongst your colleagues, talk to other people. When in doubt, call me. I'll answer your questions. If you ever need someone to be an advocate for you with your medical direction, your hospital, your floor, whatever, contact us. Contact us, Trauma 1, contact me. We'll be advocates for you because we all need to be practicing evidence-based medicine both in and outside of the hospital. Any questions, you're welcome to email me, or there's a contact sheet on the website. That's it. Thank you.